Hi, everybody. Welcome again to Anatomic Insights into Common Pain Problems. Today, we'll be discussing Poppy the Popliteus. And I recommend that you submit comments. Let's have a discussion. You can react, tell me that sound isn't on, whatever you want to do, because it takes a lot of people to help get these things just right. And I want to give a special thanks to Nancy Howard, who's the expert that put together my video streaming studio. We're always messing with stuff, so that's why maybe we had a few minutes delay. We were just getting everything right, but without her, this would not have happened. So thank you, Nancy. And also, before we get started, just a reminder that this isn't medical advice or veterinary advice for anybody. In particular, this is general information only. And we want to make sure that the audience that I'm targeting, know that that is for veterinary professionals. We'll be talking about some human things too. But if you or your animal have any problems, consult your own physician and your own veterinarian. Okay, so why do we care about Poppy the Popliteus? Well, it should pop into your mind whenever you are evaluating an animal, because I'm going to say we're all veterinarians or interested in veterinary medicine, but this is, again, for educational purposes. And I do have a human knee model, mainly because there's so much more information available and good models available for the human. But good for us as small animal practitioners is that there is verification that the popliteal attachments and the function is pretty much the same across the small carnivores, so dogs and cats, as well as humans. So we can use this as a model. We're not so informed about the popliteus in horses and goats and other large animals. In part, when they don't have a fibula, we're not getting those same attachments. So we'll go over the attachments soon. But yes, Poppy the Popliteus should pop into your mind whenever there is a patient that is presenting with a knee or stifle issue. Why is that? Well, because especially for humans, we get Baker's cysts, which is an outpouching of synovial fluid at the back of the knee. You could also have a popliteal pseudoaneurysm and other things too, as well as lymphadenopathy. But we're not going to worry about that right now. But just realize, because this muscle isn't discussed in most anatomy classes, and in fact, this model didn't even have a popliteus before I attached one with Play-Doh, which then had calmed down. So attaching it back there, and just realize here with the pipe cleaner that it is deep to the tibial nerve. So we're going to be talking about Poppy and why it can come up in animals, issues with the knee. It can often be also confused with instability. So much of the time with I'll just focus on veterinary medicine now. So much of the time in animals, if let's say a dog or cat has pelvic limb lameness, then what do you think about first? Oh, must be an ACL. And then what are we taught to believe in vet school? Oh, well, therefore, if it's an ACL because they have a lameness, then they must need a TPLO. And those of you that have followed me over the years, I can't stand the TPLO and I would never recommend it. But anyway, so this is part of my anti-TPLO campaign, because you should be examining the animals. If somebody does come in with a label on their butt or with pelvic limb lameness, then what do? We palpate the back, we palpate the whole animal, but we want to palpate the pelvic limb circumferentially. And good morning, Ginger, as well. Thank you. I'm glad you're hearing me well and appreciate your comment and your being here. So we want to palpate areas, the whole dog, circumferentially, whether it's the neck, the back, the abdomen, the trunk, and the pelvic limb. So next time we'll be discussing the biceps femoris, but so many things can refer pain and have dysfunctional consequences on the knee or the stifle. So we're going to examine the quadriceps, all four of them, the hamstrings, all three of them. We want to find this special flexor of the knee or stifle. That's the popliteus, and that's where we'll find it. We'll get back to that. And then all of the muscles around the cruce, the extensors and flexors, and then the tarsus and the pes, and both sides. Because when you have popliteus dysfunction, you could have instability of the stifle, whether it is anterior, so cranial, or caudal, medial, or lateral, because it attaches to so many different things. But one thing that I think is not on most veterinarians' radar, not on most physicians' radar either, is caudal instability. So again, we so often think about cranial cruciate injury if the dog is lame, till proven otherwise, even if it's stable on a draw test. So, but who here thinks about a caudal cruciate ligament instability? And part of why I'm so interested in Poppy the popliteus is because I tend to get that dysfunction myself. And how I know that is that I get trigger points or pain just distal to the popliteal fossa here in the proximal calf. I find that going downstairs or going down hills, that my femur wants to go forward and translate too far forward, and the tibia not so forward. So when we're doing a drawer test, that we think about cranial cruciate ligament laxity when the tibia comes forward more than it should. Well, how often do we think about caudal? And so we'll talk about that shortly. But that's how I know it, is that the femur is sinking forward. But if you have an animal who's having dysfunction in the popliteus, which can be fairly common in humans, and it's just not thought about in dogs, but similar biomechanics and such, aside from not being bipedal, then this thing could be causing problems and never being detected. So let's talk about where you can find it. So think about, or you could stand up right now, and when you have your hand at the back of your knee like that, you are in popliteus territory. So the popliteus is going to be, let's see, we'll get this on the camera in a close-up. But the popliteus is going to be right below your popliteal fossa, right there. And here's an image of it in the horse. And the horse doesn't have anything more than a vestigial fibula. So it's a little bit different, a little bit less connectivity there. And so here we have just a review of what's involved in the knee. And again, this is human. So we have the patella, we have our quadriceps coming in the front, we have two menisci, a lateral and a medial. This is important because Poppy the popliteus, let's get back to here. Poppy the popliteus is also considered nowadays, there's a thought that it should be considered the fifth ligament. So if we're talking about ligaments, here's the cranial view again. So patella, quadriceps coming down, inserting on the tibial tuberosity, and here's the fibula. We can think about the cranial and caudal cruciate ligaments, move the tibial nerve out of the way, so we see them from the back. And we can talk about the lateral collateral ligament and the medial collateral ligament. So that's 4. But people are asking now whether, I'm just going to remove the tibial nerve, realize, I have it here, because realize that it is actually over the popliteus. So the popliteal muscle is so deep that it is actually deep to the tibial nerve, number 1. Number 2, I've seen a study asking about, well, when we're going to treat the popliteus for trigger point pathology, can we do deep needling? And because, there's a lot of fear about doing deep needling naturally around the popliteal fossa, because we have the tibial nerve, the tibial artery or popliteal artery and vein, and the saphenous vein in the back. So lots of stuff, and lymph nodes and whatnot. But this one study looked at needling the popliteus, which would be down here, and saying it was perfectly safe. Well, you know, if you have the tibial nerve going right over it, and this point here would be bladder 55, so it's just too soon distal to the popliteal crease. I don't know, the tibial nerve seems quite available for penetration there. So I don't really like that. But the significance of the popliteus, back to that, is that, yeah, I think it could be functioning as a ligament. It's muscle tissue and it contracts, but it's so deep and it is helping stabilize the knee or stifle. So it's actually, let's see if we can look at it from the side so I'm not having to hold it quite so much. So this, I just developed a popliteus for the dog right here on the left hind limb, so you can see where that would be. And you would go just distal to the knee joint right there. You're going to have it, neurectomy there. You're going to have the broad attachment to the medial surface. So when you think about it, for those of you in my classes, that we often talk about the pes anserinus. So the pes anserinus coming from the front, we'll revisit that. So just behind that is where that popliteus is going to attach, and then it's going to come around, and I made a little bit of a lateral collateral ligament right there. It's actually deep to the lateral collateral ligament. So thank you, dog. And that's what I wanted to show here, was that the popliteus, so these are all structural items of significance, so anatomic insights into pain problems, dysfunction. What do you think about this? The popliteal tendon is originating, I'm going to do a fibular nerve neurectomy there. It's originating on the kind of the anterolateral, or a little bit cranialish condyle of the femur here. And so it's coming from around there. It's going deep to the lateral collateral ligament. It is attaching to, where are we? I have to work backwards here. Attaching to the lateral meniscus. That's huge in itself. Think about what we just talked about. It's deep to the lateral collateral ligament. It's attaching bone to bone. It's and it's also sharing fibers with the lateral meniscus. I mean, when we talk about proprioception, so where your stifle or knee is in space, and how are signals going to get to the brain through the peripheral nerves. The popliteus is supplied by branches of the tibial nerve, which branches off the sciatic nerve. But it also, because the popliteus is involved in unlocking the knee, remember, it's the key of the knee. So when we initiate weight bearing as a human, probably as a dog too, we initiate weight bearing, we're coming from a fairly locked extension position, and then we're bending, and so this floppy Play-Doh popliteus isn't really contracting, but what's happening is that popliteus, with its attachment to the lateral meniscus, it's going to bring the lateral meniscus a bit more caudal, and so it doesn't get misshapen and squished when the femur is coming back here. So there's a lot of significance in the fact that the popliteus and lateral meniscus are attached. And then before I took it off, it's coming from deep in here, and it's going to fan out, and it's going to attach down here at the caudal tibia, caudal media tibia, and then remember that here is the pes anserinus coming in through here. I have an even better model, but that I'll get in a second. But the other attachments that it can make are to the femoropopliteal ligament back here. So it has like 5 different attachments to muscles, to bones, to ligaments. So it's very highly involved in coordination of things. Let's see. So this is another knee. And again, you're not going to find this kind of thing in non-human models. So move my popliteus out, move this guy. All right. So let's reorient ourselves. Where are we? So this is obviously cranial, and this is the shared quadriceps tendon coming down and inserting on the tibial tuberosity. So where are we? Where do we have a fibula? And also in the human, this is your iliotibial tract. Let's take that off. Done. We could even take that off. Okay, so we can begin to see the articular surfaces of these of the knee joint. And if we come up here, what's in here that you might not be able to see that well are the cruciate ligaments. And obviously, the hamstrings want to come off. We will accommodate them, little vastus, or the semimembranosus. So what do we have here? What attaches just above the popliteal area? These are your gastrocs. I'm going to take those off. And look who we have here, Poppy the popliteus. So take off some muscles of the crus and soleus, not apparent in the dog. So we have a beautiful view of Poppy the popliteus here, and they've done it pretty well. So they've shown how the tendon, which can be ruptured, especially in athletes, human, it's been documented quite a bit, and then it leads to a whole bunch of knee instability. So it's coming deep to the lateral collateral ligament. The tibial nerve is not shown on this one, but it would be coming over here. And then you can see how it's attaching to the lateral meniscus and sweeping around in a fan-like fashion over here. Now, before we took off some of the other muscles, they were showing how they would insert here medially, craniomedially, and you can see some of the remnants of attachments here. And that's where your pes anserinus is, that we consider so important for knee stability and the afferents coming in. That pes anserinus, again, coming through here. What are the three muscles? I always quiz my students. Sartorius, supplied by the femoral nerve. Gracilis, supplied by the obturator nerve. And then the semitendinosus, supplied by the tibial branch of the sciatic nerve. So right there, we have three different nerves and three different muscles coming in that are relaying information from the craniolateral pelvis, with the sartorius, the medial surface with the gracilis, and the caudolateral with the biceps, with the semitendinosus. And what do we do with a TPLO? We screw that all up. We lift those muscles and cut in through here. Part of why I don't like the TPLO. But anyway, so right behind there, though, in a very important area, is Poppy. And this is her fan-like attachment that is coming out and acting like a stabilizer ligament, possible, potential flexor of the knee. But it's really when you're just starting to take a step. So you want to find it on yourself? Let's do that exercise next. All right. Sorry for my muscle pile here. So what I'm going to do, if I don't fall over, you can practice this too on yourself. I'm going to show you my leg right here. All right, let's move this. Whoops. All right. Well, that was interesting. There we go. Okay. So, you want to find your popliteus. Let's zoom in. Okay, here's what you're going to do. So we know that the popliteus is coming here medially. And what the popliteus does is it initiates with a internal rotation of the tibia. So if you're not bearing weight, that's what that's going to do, is internally rotate the tibia. When you start to stand, it's going to actually externally rotate the femur. And so one thing that happens in humans that have had stroke is that they kind of permanently in tow with their tibia, and that can lead to movement dysfunction, even instability. And what's the cause of that is shortening of the popliteus. So again, if you don't know where to find it, then how can you treat it? So we'll talk about treatment in a bit, but I want you to find it here. So just go to your pes anserinus here, just distal to that tibial condyle, medially right there at spleen 9, and go right behind there, and then kind of internally rotate your foot, which is going to internally rotate your tibia. Let's see. There we go. Internally rotate your tibia. So if you're too far forward on the pes anserinus, you're not going to find it. You got to go caudal to that halfway mark, and then you will feel it contract. And so that's where you can begin to find it. That's where you're going to locate this part right here. And so if we wanted to do treatment then to fix this, excuse me while I remove my quads. Okay. What acupuncture points can we use? All right, let's think about this again. I'm missing my patella. It got taken off with my quads as a sesame bone. But anyway, let's do a quick review of the acupuncture points. We have our fibula here. So this is lateral. Don't need that muscle. And so just a quick review, lateral is going to be stomach 34, spleen 10. If we had our patellar ligament here, we'd have the eyes of the knee with stomach 35 here. For distal to the joint, we'll have stomach 36 and spleen 9 at our pes anserine. And then in the back, remember, we have bladder 40, the middle of the popliteal fossa, and then on that lateral aspect of the popliteal fossa, we have bladder 39. On the medial aspect, something we don't teach much in the non-human is kidney 10. But what's here over Proppy? Well, bladder 55. So if you haven't ever used bladder 55, this is where it is. And you can look it up in my book if you have a copy or just on the internet. Bladder 55. What is that point? Well, it's called, the Chinese term for it is He Yang, which means confluence of yang, which could mean just that there's a bunch of different muscles coming through here and the nerves and the vessels. So lots of things happening. And, but again, what do we do? Do we deeply needle it with a 40 or 50 millimeter long needle? Probably not so much because, again, I'm showing you that there is a tibial nerve right on top of that. So I wouldn't do that. What we can do is really meld into the tissues, and you're going to have to get by the gastroc medial and lateral heads. But you can do it, but you have to, it's a very, very deep muscle, so it's going to be more tricky. But what I can have found effective, especially in the humans that I've saved from knee replacement because their knee kept on locking and it wouldn't work and they were slated for a replacement, then it's like, hey, it's your popliteus, we can fix this. And so I'll come in from the back and do pressure just distal to the popliteal fossa. So we don't want to squish important things, but we want to be very gentle and mindful. And again, this is only for educational purposes, not telling you to do this to your own animal if you're not a vet. And then we're going to do some lengthening. We're going to do some direct myofascial release or indirect myofascial release, which is my preference, as well as potentially laser. Laser could be really great there, especially with a class 4. I think it would go more deeply. So that's where we're going to look for it. And it's going to be distal. And now that we know where it is, you can find it. You've felt it on yourself, find it on your patients, and let me know how it goes. Email us at info@curacor.org, and hope that helps give you some anatomical insights into a common pain problem, which is the stifle, which is not always a cruciate ligament problem. All right, so next week, we're going to be talking about, or in 2 weeks, next time, we're going to be talking about the big and friendly big and friendly biceps femoris. How is that big and friendly? Well, it's very big. Um, it's so big that when we had my go back when we had our medical illustrator design our anatomical plates for our classes, that he had made the biceps femoris really big all over the place coming around here, and I thought that is too big. The biceps femoris isn't that big, and now it's in pieces here, so I can't show you on the human, but it actually is really big in the dog, and probably the horse as well, partly because as quadrupeds, they do get more developed in their hamstrings than the quads. So anyway, the biceps femoris is so big that it is attaching to the calcaneal tendon, the crural fascia, the cranial margin of the tibia, the tibial tuberosity, and the patellar ligament. Tell me that that's not important for your best diagnoses and assessments of your patients, because it is. So we'll meet next time. Thank you. Email me. You're welcome. Appreciate your attentiveness, and always feel free to email us and suggest more pain problems that you're struggling with. Okay. Till next time. Thank you.